We will now start our first panel discussion. Dr. Richard Dart will act as our moderator. We'll welcome Dr. Dart back to the stage.
Hello, everybody. So I've got a few questions. Hopefully this will lead to some discussions. And we've got a fair amount of time, so I'd like to, more than one panelist can comment on these questions as well. First, I thought I would start with Lindsay, put you on the spot right off the bat. You know, the naloxone issues are so close. You know, I'm an emergency physician, and as is my wife. I mean, I know everyone I know is an emergency physician, it seems like. And we have this phenomenon where patients come in, they've just recovered, perhaps they got naloxone, but they survived an overdose, near-death experience. And the majority of them, the vast majority of them actually refuse treatment with any type of medication-assisted treatment. It's always struck me that here, in that situation, even then, they are not interested. I want to relate that back to naloxone, though. So do you think, your presentation was excellent and very clear, but do you think that, I mean, I guess the question is, can we get there? Can we get to a state, how can we get to a state where people who don't seem to be particularly concerned about their outcome, at least in the short term, right, at that moment, are actually carrying it or having their friends carry it, et cetera. So please take a shot at that. And if the other panelists want to comment, that'd be great too.
Yeah, please, everyone welcome. This is going to take more than just me to respond to. But I actually am in an emergency medicine department here at Northwestern. I'm not an MD by any means, but I get to hear a lot about this very issue from my colleagues. And I think one of the themes I go back to again and again is the need to more broadly conceptualize treatment of substance use as a medical condition and destigmatize it. So of course we need to destigmatize it. Everyone will agree with me on that. But the substance use treatment infrastructure kind of was born out of itself. It kind of was, it came up adjacent to the medical treatment infrastructure. And so it used to be considered this moral failing rather than a chronic condition that needs to be treated. Right. And so I think one of the first steps is really decoupling that and incorporating this idea of prevention and management, just as we would for care of diabetes or heart failure. Right? But I think that would help take away some of the stigma that often keeps people from wanting to engage in treatment. And I use the example often of women who have children. There is a big fear of women who have children getting their kids taken away from them because we are continuing to criminalize substance use. So I think one of the things we can do is put not just legal policies that decriminalize, but truly offer resources for people to get the medical treatment that they need in a way that's comfortable for them. And so can we get there? I think it's going to be a really long road. So one of the ways that we can get there is through these harm reduction programs, which are always, always controversial. A lot of people think that when we say, hey, come and shoot up near us, we'll watch your kids while you do it, and we'll put you in a padded room so you can't hurt yourself. People say, well, we're just enabling drug addicts. What these people don't realize is that is the front door to treatment. So yes, we bring them in and we help them, engage with their drug of choice more safely. But then while we're there, we say, hey, take this naloxone with you. Hey, why don't you talk to my buddy over here? He's a peer recovery support specialist. I see that my panelist, Matthew, is nodding. So I might yield the floor to him and allow him to enthusiastically contribute his content to this.
No, I was just wholeheartedly agreeing with everything you were saying. I think in particular, the research has shown there's also issues with one's perception of overdose risk. I think many people perceive themselves as knowing what they're doing, and so that their risk of overdose isn't as high as maybe we would think it should be in their perception. And so I think that is another reason why harm reduction places are so important, is that you have peer specialists who are communicating with them in a way that they understand, in a non-stigmatizing way, and can help them understand both helping with their perception of overdose risk, but also understanding the market and drug supply in a way that shows them why their overdose risk exists and why the need for naloxone is so important.
So Matt, are you saying, and I'm not disagreeing or anything, but just for clarification, that the idea is that you would motivate the individual to say, I need to have naloxone with me, or at least with one of my friends or whatever, plan ahead a little bit in order for this to work. Because my view is really, it's a great discussion. We could talk forever, but I mean, these patients that come in, they just essentially died if it wasn't for naloxone. They're sitting there, they're now recovered, and they're getting ready to go, and you say, hey, we have on-demand access to methadone or buprenorphine in our emergency department right now. We can start you right now, follow-up clinic tomorrow, and you're good, you're on your way. Only a few % agree. So there's some perceptual, it gets at what you're saying, is there's some perceptual thing there that I don't know if it's even possible to change it, but somehow I agree with you, we need to change it because that risk perception or whatever it is just not there, apparently.
I do think you hit the nail on the head there with, we can start you right now. I think sometimes that we can start you right now is intimidating for people.
Yeah, maybe. Yeah.
I have to quit now. This is such a huge part of my identity. So I think kind of moving them more gently along the kind of continuum. We could say, hey, why don't you just talk to my buddy over here? I'm going to have him reach out to you tomorrow, rather than, will you quit, right? Will you sign an oath in blood that you will quit? So I think more
well, they're not, I mean, no one asked them to do that, but they would have to take their first dose of medication, and that's sort of the same thing. So, yeah, I mean, that's true. I don't know how many, because they give them materials and stuff too, and how many actually follow up later. I don't know the answer to that. So that's great. That was fascinating discussion. Next question we'd like to talk about is, this one's for Marta. Hey, Marta, thanks for your talk. So you've been working on opioids for probably 20, 25 years now, in multiple different capacities, I would add. I mean, if you had, what would you like to see in terms of data, post-marketing surveillance of medications that are coming out? I mean, obviously, I'm talking about from the FDA perspective, although you can answer more generally than that if you want to, that we either don't have today or should strengthen or should get rid of, for that matter, in the future.
So you started the question with asking regarding opioids, and I would pivot to polysubstance use.
Okay.
I think we are very much focusing on one substance at a time, and one thing that I think I have learned is that it's rarely one substance at a time. A number of the presentations have confirmed that it is rarely one substance at a time. So if we are trying to just adjust one substance at a time, we might be playing a whack-a-mole. And really looking at the patient holistically and all the drugs that they are using, how they are using it, it's a better way to approach it. So really looking at the dynamic of in post-marketing, how they are using the different substances. And we do have some very interesting information. I have to admit, I'm very curious how the information regarding GLP-1s and the issue of craving more broadly is going to be impacting our perception and treatments for potentially for substance use disorders, not only for one at a time, because it could really shift our thinking in the approach. So if you ask me what I would like to do for the next few years, it definitely would be to focus on the post-market, the polysubstance use and look at it more broadly.
And Matt had some great points about the polysubstance use, which we all, at least I often fall into, right? I use the term differently depending on the context, meaning sometimes I mean simultaneous use, sometimes I mean they used them both in the past year or whatever, right? Any ideas on how we should define that? Just either you or Matt can comment. You didn't commit, Matt, but do you have any other thoughts on that?
Yeah, I think, I'm working with people now where we're doing a systematic review of understanding how people are using polysubstance use in the literature. And it really is all over the place. And I think I'm happy to see this focus on polysubstance use, but it's really broad in how we're defining what that means. And I do think ultimately we need to get to a place where we understand use with overlapping effects. But also to say that one thing that we found in polysubstance use is that there's a focus on specific drugs where some polysubstance use papers are focusing just on stimulants or opioids, or they're focusing on, and really, to Marta's point, we need to focus broader. And I think in particular, alcohol plays a significant role in this, but often we focus on illicit drugs or prescription drugs, and things like alcohol tends to fall out, even though it can play an important role. So when we talk about polysubstance use, we really do need to be thinking of anything that's being used at the same time or with overlapping effects, but also potentially those long-term effects, if you're thinking about cannabis use and cardiovascular issues, particularly in older adults, all these things are overlapping with one another, both in short-term and long-term effects. So I think we really need to think through structuring polysubstance use research in a more thoughtful manner.
Marta, any thoughts? Because I think from FDA's perspective, so you notice Matt didn't actually give me a definition there, but which I don't blame him. It's impossible. But do you have any other thoughts on that? Because I want we would like to go down that path and say, okay, we're going to come up with different terms. I guess I would say, right? If you have used in some reasonable proximity your one name, if you're using them together to magnify each other's effects, things like that, like a speedball or whatever, that's a different type of polysubstance than I drink alcohol too much every day, but on top of that, then I do other things. So any thoughts there? Because it's something I've really struggled with trying to understand this, or try to come up with a solution to it, I mean.
I think you just discovered the next topic for the 20th annual meeting, because I think that is a topic that should be more discussed, how we define it, and does it even, what proximity matters, and how do we have different patients' profiles based on the different patterns of use, how we should tackle it. I think I'm definitely not ready to give you an answer or definition. If you have one, I'm happy to consider.
I don't.
It's more to discuss, I think.
Yeah, and I think there's a ramification of this that fascinates me, because we basically turn a blind eye, right? We say, and I just did it in my presentation, these patients endorse non-medical use of an opioid. I didn't say anything about the other drugs that they're using. And yet, as we were just saying, that's an important context. And so how do we address that going forward? Because what every researcher is doing right now pretty much is reporting on a drug and making some important points, but just, I guess, assuming that the background of all this is the same, when it almost certainly isn't the same in terms of polydrug use, polysubstance use. And we have no, FDA could convene a panel to try to define these things and to put a structure in there, because I think it's really, I don't know how I would do it, but it really seems like an important topic, which I have beat to death, so I will move on. But
if I could just add one thing,
sure.
And it is really important, because otherwise data can be easily misinterpreted and deceiving, that, we had decrease in, binge drinking, or in nicotine or tobacco use. What you don't know is that the people who increased cannabis use likely compensated for decrease in the nicotine use. So the patient is the same. And if you don't address the patient as whole, then again, you miss the mark. And if you are trying to address the treatment and you don't recognize that this is the patient actually who might be using both, you might not be able to address appropriately the withdrawal symptoms, for instance, of a long-term craving that might be coming. So
absolutely true. Go ahead.
May I jump in here too?
Sure.
with a thought? So one of the primary data sources that researchers use is death records, and we have this real challenge with the way death records are coded in each state being very different from one another. And even within a state, things are inconsistent. I was just on a call with, I'm a Medicaid policy researcher primarily. So I was on a call with West Virginia Medicaid yesterday, and they said that they were having to go through and do some retroactive quality control because so many of their death records had cause of death or the drug of death listed as cannabis. And we know that that isn't frequently the case. It's just that cannabis is one of the many things that pops up in individuals who die from an opioid use or other polypharmacy makeup. And so their polydrug use. So I think not just standardizing what this means for all of us, trying to come up with kind of the epidemiological, how are we measuring this across the country, but also understanding that we have to standardize this even for decedent data, and that we can also be getting a lot of mixed messaging just because of differences in the way things are coded on death records.
Oh, yeah, that's so true. And actually, thank you, because it's a great segue into my next question. So several of us showed data. We showed that Hannah showed that antidepressants seem to reduce. The use of an antidepressant is effective. We showed that Marta mentioned that cocaine use is going down. The problem is when we look at the mortality data, then cocaine mortality is going up. And actually, I didn't show it because I didn't have enough time, but it's fascinating to look at some of the other drugs like benzos and like antidepressants, because if you look at antidepressant mortality, with those limitations for sure, but it's doubled over the last, I think it's the last 10 years, but it's going up distinctly. It's not anywhere near as high as the others, but still, it's like, to me, it's like, how do I interpret the national mortality data when it doesn't seem, it seems a lot different than the non-mortality experience that people are experiencing or reporting in their research. And this is open to anybody, really, because anybody could answer this. I can get someone in the studio here if you want, but go ahead. Anybody want to touch that? Because it's a tough one.
I like to go first because then I can just say turn it over to somebody else. They can fill in any gaps.
Okay.
But I think whenever I'm looking at the data, seeing rates of substance use are increasing, and deaths that are associated with antidepressants are increasing, I like to remind myself that so much of this is because we were doing a better job of treating people, and we were doing a better job of diagnosing. We're doing a better job of getting people the treatment that they need. And so if more people are on antidepressants, we know that they are largely effective in reducing suicide and other related deaths. But there are people that are going to die. And the more people that we have successfully reached, I'm not going to say successfully treated because the result wasn't what we wanted, but I do think that there is a silver lining to this, and that we are treating more people and we are diagnosing more people.
That's a great answer, and actually, it's the same answer that Hannah gave me when I asked her off stage. So very good, very good. So we have two people agreeing. It's got to be right. Now that makes a lot of sense. Makes total sense, and I think it's one of the nuances of interpreting data both on misuse, abuse, opioid use, or substance use disorder, and mortality that unfortunately is missed by the press generally, right? They focus on the mortality data, which is by the time people are dying from a drug, that's usually several years after that trend started, right? Because it had to build and get to the point where enough people were passing away to be counted. Excuse me. I won't go there because we could talk forever on that one too. Any comment, Marta or Matt, do you have any comments on the relation of mortality data to our other data sources?
I agree with Lindsay because I think gabapentin's another good example of that, because we've seen increases of reports where gabapentin is being increasingly identified in overdose deaths. There was a study in St. Louis that looked at urine samples and found gabapentin was a most frequently identified drug, even more than fentanyl. The question is that because prescriptions have increased and it's just being out and diverted more, or is it because people are purposely using it for specific reasons and it's having a relationship with opioids? I think those are the questions that we need to look into deeper when it comes to prescription medications. Is it just a greater amount is out there, and so we're obviously going to see it more, or are there specific, mechanisms of action that are increasing your risk of death?
Yeah, that's fascinating. Do you think? So some people would propose gabapentin, as they have buprenorphine, for example, to be almost harm reduction, meaning, yeah, that's okay because they're not going to die from that. But I got the hint, or I got the suggestion from your talk that maybe that wasn't true. Would you care to elaborate on that?
Yeah, in the research we've done on gabapentin, we do see similar motivations for using gabapentin in terms of they're using it to help them sleep, or they're using it to self-manage their pain or withdrawals or anxiety. There's lots of self-management motivations for using gabapentin. But what we also see is that people use it to potentiate the effects of their buprenorphine or methadone, which was reported about 20 years ago in the literature, but it didn't really go anywhere. But now that we've seen gabapentin use increase, we found that the majority of people who are non-medically using gabapentin were also non-medically using buprenorphine or methadone. So there may be a relationship between the two. But again, in the substance use research, there's not a lot going on with gabapentin. But from my talk earlier, I mentioned that in the pain research field, they have been looking at administrative data showing that if you have a co-occurring prescription for gabapentin and opioids, yes, your risk of adverse events, and in particular respiratory depression, increase significantly. So there may be some biological mechanism between opioids and gabapentin that is leading to that increase in overdose deaths.
Wow, great. Okay, we have a few minutes left. I wasn't sure whether to ask this question, but I'm going to. So you all presented data, I presented data on what I view as, I guess as an old timer, as this incredible rates of at least non-medical use, but also misuse and abuse. I've not added this up, but I want to ask you guys, if I take all the substances that are abused, alcohol, all the illicit methamphetamine, cocaine, fentanyl, but all the prescriptions, including the benzos, etc., I get the impression, and you can slap me down if you want, but I get the impression that over half the people in our country feel like they have the need to medicate themselves to make it through their lives. I know that's a big overarching question. Do you agree with my estimate? Although it's a very general estimate, but what do you think about it? Is this all a few people that we shouldn't be worried about? Which I think a lot at times in the press is sort of like, well, there's quite a few, but it's the small minority of the U.S. And I'm getting the feeling that it's not the minority. We need to say to ourselves, why does the majority, or at least a huge part of our society, feel the need to self-medicate?
I think it is a sobering comment, and you're right. When we are looking at the data across all of our presentation, we are seeing these staggering levels of substance use, both medical and non-medical. And when we zoom out, it does start to feel like we're looking at a collective signal of distress. And so when we are thinking about why are so many people self-medicating, the answer, it's not just pharmacological, it's sociological, it's economic, and it's very human. So people they're not reaching for substances because they want a better high. They're reaching because they feel pain and they want to stop feeling pain in an emotional way or a physical way. And so I think we need to offer systems. We need to put systems in place that offer people a way to feel kind of safe and supported and connected without feeling the need to numb out to survive.
That was perfect. Thank you. That was a great statement. Seriously, it's one of the things that bothers me the most as I get old and older, at least, is this. It's distressing because we've been going on now. If you look at the curves on all the drugs, it's at least 30, 40 years of increasing misuse and distress that you're describing. that we have not effectively addressed in this country. I'd be happy to end on that statement. There's a couple small questions left, but why don't we ask you, do any of you have a final comment you'd like to make to the audience before we go on? Just let me off the screen, right? That's what you're thinking.
I just want to say thank you very much for the data that you continue to provide through your system, through these meetings, because it really helps me to think more broadly regarding not only regarding the actions that I can talk about right now already because they are public, but also as I'm thinking about actions that, in FDA speak, it takes a while to get things rolling. But really trying to identify the future signals and try to figure out how to focus our policies, whether to direct drug development or to think about addressing harm reductions or whatever is the topic of the day. These meetings are really helpful for us to think if we are, if there's something new that we have to do. So I just want to say thank you for that.
I'd like to add to what Marta is saying, because she did say policy, which is the magic word that activates me. I'm a policy researcher at heart. I think expanding our understanding of what substance use policy is beyond what might traditionally fall in that lane. So understanding that things like housing and employment and Medicaid cuts and SNAP cuts, these are things that all contribute to people feeling the need to numb out, and then also not being able to stay connected to society and to treatment in a way that makes them feel useful and productive. And so I think we need to look at the policies that Marta is talking about and then expand the definition outward to include a health in all policies perspective, and look at what we're doing with education and with housing and with employment policy as well.
Great, thank you. Well, that was a great session. Thank you very much. And I'll turn it back over to Kate. Yes, go ahead. And thanks again.
Thank you, Dr. Dart. That wraps up our morning panel.